Well, hello, and welcome to this lecture discussion of some of the smooth muscle tumors we encounter in the uterine corpus. Our objectives today are to cover three principal areas. One is the smooth muscle tumors that are benign as opposed to those who are malignant, and how we differentiate those from endometrial stromal sarcoma, what's key to not missing that diagnosis. And finally, we'll touch on some of the things that we put in the report and how that may impact treatment or prognosis and some of the tools for determining that. So we want to start with the benign smooth muscle tumors. And first off, want to acknowledge the great resource from Drs. Clement and Young. Some of the images from their textbook I will be using rather liberally to illustrate the points in this lecture. So smooth muscle tumors are something that virtually every surgical pathologist encounters, very commonly found in the uterine corpus, usually multiple, have sharply circumscribed borders, sort of a whorled and rounded cut surface, sometimes bulges away from the surrounding myometrium. It's said that these occur in 75% of uteri, and most of the time, 75% of the time, they're multiple. In terms of sampling, sometimes we have dozens, so sampling every one may not be required, but sampling should certainly be directed towards the largest mass and any that look different from the rest. In terms of symptomatology, subserosal as opposed to submucosal lesions can certainly produce different symptoms, bleeding and prolapse and so forth, much more common with the submucosal. Pain or no symptoms with subserosal lesions. Benign tumors may become infarcted and may have adjacent mitotic activity, which can make that a difficult challenge to differentiate from malignant lesions in some circumstances. So here's a typical microscopic image showing the whorled fascicular nature of these cells, elongated nuclei, hence the name spindle cell. And here we see sort of rounded cigar-shaped tips as opposed to pointy tips with sort of fibrillar pink cytoplasm and very mild or minimal atypia, just slightly coarse chromatin is all we would expect to see. However, other patterns can occasionally intervene, making it sometimes difficult to tell if it's smooth muscle or something else. For example, we see here the very hyaline pattern with compressed nuclei. In this pattern, elongated eosinophilic bodies of hyaline fibrosis can be seen, and occasionally even verrucae body-like lining up of the nuclei as we would see in some neural tumors. Here's an example of the necrosis that can be seen. As you see, sort of an infarct-type necrosis, a geographic zone with the surrounding peripheral edematous zone of cells, as opposed to tumoral necrosis, where usually the tumors are right up against the area of necrosis. Here there tends to be a reactive zone, and it's this zone where we can see mitotic figures. Another example of a very more common change, a hyaline fibrosis that can be seen in these tumors, but that can also lead to areas of necrosis, as we see sort of hyaline necrosis here on the far left of this tumor. Now, many times because of size or symptoms, radiographic embolization will be attempted to try to reduce symptomatology or make surgery easier, and this itself can introduce some artifacts. So here the thrombotic material is a sort of bluish color, and it's induced sort of a organoid differential pattern. Here we see polyvinyl alcohol with the foreign body giant cell reaction around the periphery. And this can be a little bit disconcerting if we don't recognize it for what it is the first time we see it. Now, a variant of leiomyoma is the so-called cellular leiomyoma. This is usually not quite as well circumscribed and has a degree of overlap with endometrial stromal sarcoma or endometrial stromal nodule in that it can have fascicular growth, spindle-shaped cells, and up to 40% of these can be positive with CD10. So how are we going to differentiate those two lesions? Well, both tend to be well circumscribed, but endometrial stromal sarcomas may be more likely to have tongue-like projections into areas. The pattern in endometrial stromal sarcomas is usually more diffuse rather than fascicular. They're usually spindle-shaped cells in leiomyomas. These are more oval. Vessels is something that I find is very useful. In endometrial stromal sarcomas, the vasculature is very thin-walled. It's very small and fairly uniform throughout. Whereas in leiomyomas, you tend to have more thick-walled vessels and variable sizes. Cleft-like spaces are more common in cellular leiomyoma, virtually not seen in stromal sarcomas, unless it's the area that's separating the stromal proliferation from the smooth muscle or a vessel. And again, as we've indicated, CD10 may be overlapping, and Desmond or Caldesman have been found to be useful in differentiating those, except in the case where occasional smooth muscle or occasional stromal tumors may have smooth muscle differentiation, but that is less common than one would than should be too much of a problem. So here's a gross image of one. You see this sort of yellowish fascicular nested areas, but slightly discohesive, falling apart a little bit. And that's reflected here in the microscopy as you see cellular areas with these cleft-like spaces. Here's the variable size vessels, larger size vessels that we would associate with this. But as you can see, the margin is not really clean. It's not really sharp, and that certainly will raise concern for a possible infiltrative pattern. Here's the higher magnification, again seeing these fascicular growth pattern, bands and strands of tumor running in different directions, and again more oval fusiform nuclei. Here's a larger vessel seen in one of these cellular leiomyomas, again with the spindle-shaped cells. This should not present too much of a problem to be confused with stromal sarcoma. Now, leiomyomas with bizarre nuclei can occasionally be confused with leiomyosarcoma. We want to avoid the term atypical in this situation because that is often misunderstood by those who read our reports, and they may be confused into thinking they're dealing with a low malignant or uncertain malignant potential tumor. Bizarre nuclei may be present focally or in many areas, and usually the true mitotic activity is low. Though sampling should be adequate, and you may occasionally want to consider a stain like a phosphohistone 3 stain to verify that the figures are not mitotic figures, but are actually just bizarre nuclei. If we find a TP53 mutation or elevated Ki67, or possibly P16 positively, some authors will term those tumors, smooth muscle tumors of uncertain malignant potential. So what are we looking at? Well, here's what they look like. Very easy to recognize this bizarre pattern of nuclear shapes, sizes, configurations, orientation, all different. And at higher magnification, very bizarre, funny looking appearing cells, all with enlarged nuclei and variable features. Certainly could raise consideration for some sort of a funny tumor. Other terms that have been used for this include symplastic leiomyoma. That's another term that can be used. But bizarre nuclei is, I think, a preferable adjective. And here's what some of these look like. And you can see how these could look much like a mitotic figure. Here's one that even appears to have a quadrupolar spindle. But we don't see true chromatids here. And if the phosphohistone 3 stain were performed, I think these would not be positive with that stain. Now, problematic sometimes, mitotically active leiomyoma. This is defined as a feature, as a tumor with typical leiomyoma features, but having an increased mitotic rate between 5 and 15 for 10 high power fields. These lesions are worth following up, but certainly would not warrant the diagnosis of leiomyosarcoma because there's no atypia, no tumoral necrosis. It's thought that these may be related to progestins in some cases, and that's certainly worth thinking about. Another variant is the hydropic leiomyoma. where we get very massive accumulations of fluid becoming so extensive that it becomes sort of cystic, and this may give a pseudo-invasive pattern. Here's a nice image of this showing these dilated fluid-filled spaces sort of honeycombing through the tissue here with intervening strands of tissue. So very striking and different appearance. Another appearance that can be seen here, not quite in focus, but more nested, nodular, sort of granular appearing areas of residual smooth muscle with the intervening areas just all fluid that collapses or leaks out when you incise into the lesion. And that's because this is what's going on under the microscope or in the tissue. It's just filled with watery fluid and then just residual strands of smooth muscle. Sometimes these are just very acellular areas with intervening vasculature and smooth muscle. Sometimes they're actually cystic-like spaces, performing a sieve-like appearance, or maybe just a very loose myxoid type of tissue with residual islands of identifiable smooth muscle tissue with some accompanying vessels. Any of these appearances could be seen with a hydropic degeneration change in a leiomyoma. The actual myxoid leiomyoma is relatively uncommon, and these myxoid areas may mimic invasion. So a myxoid leiomyosarcoma needs to be considered in the differential. So these should be well sampled to exclude malignancy. Here's an example, typical myxoid area here, but residual identifiable leiomyoma area here. The myxoid tissue will stain with Alcian blue, and the smooth muscle, of course, pink in that stain, a trichrome stain. And here, sometimes they can have a slightly infiltrative or interdigitating pattern. So sampling these well, looking for mitoses, looking for true infiltration versus sharp borders of the overall lesion is important. The apoplectic leiomyoma, as its name implies, is a lesion that has undergone sudden hemorrhagic infarction. And this may be related to, again, progestational treatment that may lead to even rupture in an acute abdomen in some circumstances, though that's uncommon. Here's a microscopic image and a gross image showing you the incised surface with these areas of hemorrhagic change, dilated infarction, and hemorrhage occurring with adjacent dead tissue. Another lesion to be aware of is the leiomyomas that may have so-called rhabdoid cells. These are smooth muscle cells. They just have these rhabdoid-like inclusions of eosinophilic substance in their cytoplasm that usually is myosin related. So leiomyosarcoma. This is the entity we don't want to miss. Typically presents in adulthood. It's usually solitary, but can occur in settings where other leiomyomata are present. Usually of large enough size that it stands out, 10 centimeters or greater, but obviously smaller, earlier lesions can be seen. And it's not usually well circumscribed. There's usually some sort of a bulging or interface that it looks infiltrative. We tend to associate it microscopically with high cellularity, atypia, mitotic rates greater than 10 per 10 high power fields, and tumor cell necrosis. So all of those in the diagnosis is easy. If you've got 2, 3 of them, then that may be enough to convince you that it should be called leiomyosarcoma. Some of the challenges come along, however, when we see dedifferentiated areas, high-grade areas, or where we see other features like osteoclast-type giant cells. And the immunohistochemistry, typically we'd like to see smooth muscle markers, of course, but if we do other considerations, P16 may be positive, P53 may be positive, DOG1, c-KIT may be positive, HMB45 may be positive, WT1 may be positive. So we see that we begin to introduce other potential differential considerations. Is this a carcinosarcoma with diffuse P53 positivity? Is this a GI stromal tumor that is metastasized or invaded? Is this a PComa? Is this a uterine tumor resembling sex cord stromal tumor? that has WT1 positivity. You can see the differential begins to form based on these potentially confusing immunohistochemistries. Well, grossly, these lesions, as I've said, tend to be slightly ill-defined, variable appearances on cut surface, solid areas, more hemorrhagic, necrotic areas standing out fairly easily. And here we see the necrosis. Contrast that with what we saw earlier. You see we have tumor necrosis, no reactive zone here. Tumor right into necrotic tissue, and some preservation around vessels with variable karyorrhexis and ghost cells of varying viabilities in the necrotic zones. Here's the high cellularity we appreciate with this lesion. This is a fairly well differentiated one. It's cellular, has mitotic activity, but doesn't have a large degree of pleomorphism. There's some, a little more coarsening, a little more nuclear enlargement, but this is cellularity, mitotic activity, and obviously necrosis at some point would be the defining features to classify this as the leiomyosarcoma. Well, how should we report these? Unfortunately, these are tumors that do not generally do well. Survival is certainly less than 50%. But to make things even worse, conventional staging doesn't really sort out the ones that are going to do well and the bad actors. So we would typically report size, mitotic figure, grade of tumor, degree of spread, and so forth, and that would get us a sort of FIGO staging. But that doesn't always capture fully the true prognosis. And let's illustrate that a little bit in a minute. So it's been proposed that we use a slightly different nomogram to quantify relative survival. This is based on a point system that assigns points based on age, tumor size, high, low grade, cervical involvement, spread, distant metastasis, mitotic index. And then based on those total points, drops down here to a relative survival rate ranging from, well, this is not well magnified here, from 80% down to 5 or 10%. Just to illustrate how that might play out here, let's look at two cases. Younger woman, 45 years old, she gets 3 points for that. She has a 10 centimeter tumor, that gets her 10 points. It's high grade, that gets her 65 points. No cervical involvement, no local regional spread, no distant metastasis, 0 points for all of those, and a low mitotic index, 3, that gets her 18 points. So that means that she has a 67% chance of being alive in 5 years after diagnosis. Now, if we contrast that with an older woman at 70, gets 6 points for that, a larger tumor, 20 points, a high grade, also 65 points. Again, no cervical involvement, no local spread, no distant metastases. But a mitotic index of 55, that gets her another 73 points. She's getting close to 150, 200 points. That means that her chance of survival at 5 years is 34%. Now, under the classic FIGO staging, both of these would have been stage 1 with an estimated overall survival of 55%. Well, that doesn't really tell the truth for these two patients who have different prognoses. So the nomogram can be fairly useful and would encourage its use. A special variant of leiomyosarcoma is myxoid leiomyosarcoma, which can be grossly distinctive, and you'll see an image here in a second. It has infiltrated borders, but very low grade atypia, and mitotic rate, because the cellularity is lower, needless to say, is low as well. Necrosis may be rare or very hard to find. These can occasionally be CD10 positivity and only focal muscle marker positive staining. So they're a little bit tricky if you're trying to use the brown stains to differentiate them. Myxoid change is not uniform in this tumor, and so if you can find non-myxoid areas, that may be helpful to determine this. Unfortunately, this is a tumor that has late recurrences, and in fact, that was some of the findings that led to its initial description out of Dr. Scully's group at Mass General. So here's the typical gross appearance. You see this very myxoid, gelatinous appearance. This tumor, small cysts, glistening fluid, and a very poorly defined border. Here's the microscopic correlate of that, loose tissue, low cellularity, variable areas, slightly more cellular, slightly more cellular. And so these may be the areas where you go looking for mitoses and define the smooth muscle differentiation. Here's the higher magnification view. And again, you can see there's not too much atypia here. Maybe a mitotic figure there, a little bit of hyperchromasia, but if you're making a diagnosis based on high power magnification alone, you might have a hard time getting to leiomyosarcoma. You have to evaluate the overall configuration and generously sample a lesion like this. The differential includes a myxoid leiomyoma or hydropic leiomyoma, which we've already discussed, and a myxoid endometrial stromal sarcoma, which, as we've indicated, can be particularly difficult to distinguish based on just brown stains. So needless to say, the tumors don't always read these criteria and sort themselves very cleanly into one versus the other. This category of a borderline tumor, uncertain malignant potential tumor has been created to capture this group of tumors, which have some but not all of the features of malignancy and raise concern. Even within this group, we know that there are differing rates of recurrence. For example, if you have two leiomyosarcoma criteria only, that gives you an 8% recurrence rate. Whereas if you have a smooth muscle tumor with tumor cell necrosis but no other criteria, well, that would give you a 25% recurrence rate. So different strokes here for different outcomes. Smooth muscle tumors that have bizarre nuclei and P53 or P16 staining, mutations and staining would fall into this category. And smooth muscle tumors with greater than 15 mitotic figures but no other atypia or no necrosis fall into this category. Epithelioid smooth muscle tumors have a different gross and microscopic appearance, obviously, and can occur in various sizes. They can present with both muscle marker and keratin positivity, and occasionally even HMB45 positivity, which makes them seem to overlap with picomas as well. Oops. Here's the gross appearance of this smooth muscle tumor, not particularly distinctive, a little bit more fleshy perhaps than other tumors. And here's the microscopic correlate, these epithelioid cells in nests or clusters, rounded groups, having not a spindle-shaped morphology. And here's a higher magnification showing, again, this epithelioid morphology, round cells, slight nuclear chromatin clumping. So these also can be malignant. In fact, a higher proportion of epithelioid smooth muscle tumors will be malignant than typical spindle cell tumors. And the criteria that are used for epithelioid tumors is high-grade nuclei, mitotic rate greater than 5, and any degree of necrosis. But only 2 of those are required to call this an epithelioid leiomyosarcoma. You can also use the term stump for any of those lesions that are not definitely malignant or not definitely benign in this situation. And we've indicated what some of the overlapping lesions can be: pecoma, stromal sarcoma, also uterine tumor resembling sex cord stromal tumor, and placental site tumors. Here's an image of the microscopic view showing these rounded epithelioid cells, pink cytoplasm, mitotic activity, and you can see the nuclear atypia that's here. This is not a grade 1 nuclear change. And so this has the criterion of nuclear atypia. It has the criterion of mitotic activity. We do not see necrosis in this field, but as we've indicated, only 2 criteria are required to classify it as a malignant epithelioid leiomyosarcoma. These tumors can also have a very clear cell morphology, again, showing the overlap with picomas, but also potentially with clear cell carcinomas or stromal sarcoma with clear cell change, or even squamous cell carcinoma in some circumstances. Let's talk about perivascular epithelioid cell tumors, or pecoma. These are uncommon, though increasingly recognized by general and subspecialized pathologists. They do have epithelioid and spindle-shaped cells, pale cytoplasm, nests and cording pattern, a prominent capillary network, and mark with melanocytic markers, HMB45, MITF, melon A, as well as smooth muscle markers, such as Desmond. And note that they can also mark with CD117 as well. So if they have two of the high-risk criteria, size greater than 5 centimeters, infiltrative border, high-grade nuclei, necrosis, or a mitotic rate greater than 1 per 50 high-power field, or any degree of lymphovascular invasion, you've nailed the diagnosis as a malignant perivascular epithelioid cell tumors. And in classifying that is important because certainly those patients need to be followed for recurrences because recurrences can be late in these cases and sometimes difficult to deal with. So here's the morphologic appearance. You can see this sort of epithelioid appearance, variable spindle and epithelioid cells, HMB45 positivity. Here's a clear cell version showing the tongues of cells mimicking endometrial stromal sarcoma. Here's the clear cells, and again, HMB45 positivity. Now, there are other variants that we can see, and we show you just a few of these lesions. Multicentric low-grade smooth muscle tumors, defecting or cotyledenoid smooth muscle leiomyoma, intravascular leiomyomatosis, benign metastasizing leiomyomas, or parasitic lesions that migrate and latch on to other locations. So here's lymphangioliomyomatosis involving a lymph node, small proliferation of smooth muscle cells, not mitotically active, but positive with Desmond and present in locations where it does not normally occur. Here's the so-called cotyledenoid leiomyoma, or dissecting leiomyoma, with various very spongy appearance resembling a placental cotyledons. And here's an example of intravascular leiomyomatosis, worm-like projections into vessels in the lesion. This is a lesion that's difficult grossly to distinguish from endometrial stromal sarcoma, but fortunately, microscopically does not particularly mimic endometrial stromal sarcoma. Here we can see the intravascular nature. Here's the vessel. Here's the leiomyoma type tissue in these lesions. Again, vessels within vessels in these lesions. And occasionally you'll find these metastasizing to the lung. This is an example of so-called benign metastasizing leiomyoma. Well, that concludes our discussion of smooth muscle tumors. As I indicated, we're going to post some digital slides and present video with some of those to further illustrate and give practice in distinguishing some of these lesions. We welcome your comments and hope that you will like this video and share it with others as you see fit. And come back next time for more interesting cases.